speaker. It should be Dr. Ahmed Shama, but he cannot come. So Dr. Zakaria will present his talk, role of ICL in keratoconus patient.
So again, thank you so much, Dr. Manor. Apologies from Dr. Ahmed Shama for his commitments. He couldn't come today. So on behalf of Dr. Ahmed Shama, I'm going to talk about the role of phakic IOLs in keratoconus patients. And this is the refractive rehabilitation part. So we've talked about cross-linking in children or adults in general. Cross-linking is one of the, it's the first line of treatment. And then we regularize the cornea with the ICRs or whatever you want to regularize it with, topo-guided PRK, whatever. And then you correct the ametropia or the refractive error resulting from this. So today, the objectives in this presentation is the clinical question is not can we implant, or it's not can we implant, it's in which keratoconic eye will phakic IOLs deliver the predictable and safe vision. So the role of ICL or phakic IOLs is, I'm going to define it in general. I'm going to also talk about the ideal candidates and red flags. I review some practical points, and then I will sum up at the end. Keratoconus creates two refractive problems, we all know. Progressive ectasia, which is halted, stopped by cross-linking, and the residual ametropia that results afterwards. So in the management pathway of keratoconus, we should stabilize first and rehabilitate second. So detect, stage the keratoconic eye with the topography, tomography, refraction, do all kinds of stuff, and then stop the progression with cross-linking. Regularize the optical zone using ICR as transguided PRK in selected cases, and then correct ametropia. So this is the stage where phakic IOLs fits in. What ICL brings to keratoconus care? It corrects the refractive power of the eye, so the patient can see well, but it also preserves the cornea. You're not doing nothing to the cornea, so everything is intraocular, so that's a good point as well. That's a great advantage. And being reversible is another advantage. Ideal candidates are those with stable, correctable eye. So we can have patients who have stable keratoconus, but they are amblyopic. And I think I shared the case with Dr. Iman Helmi before, a patient who had other problems in the retina. She's keratoconic, but it's not correctable. She's not correctable. So nothing would be done for her. You would not address the refractive error. For phakic IOLs, you have to have realistic expectations again. You have to have adequate anatomy, AC depth, the angle, the vaulting, all this stuff. Correct the high myopia and myopic astigmatism. Useful, look for if there's a useful best-corrected visual acuity, and make sure that you stabilize the cornea first. This is an ideal candidate where you have central cone. Dr. Nihal, this is an ideal candidate where you have a central cone with an AC depth. Make sure this is an internal AC depth between brackets on the pentacam. The AC depth that I take from the pentacam is really sufficient, and I really depend on that. It should be not less than 2.8 with some forms of phakic IOLs, or 3 millimeters in other types of phakic IOLs. As recommended by the company, and the cone is central, so you have more of spherical aberration rather than chromatic aberrations. When to avoid or defer phakic IOLs? If you have progression, if you still have progression, poor corrected, that's why I follow up the patient before taking the decision of doing phakic IOLs, not less than 6 months to 1 year even. If you have poor corrected potential, as I've just said, amblyopic eyes. If you have unsafe anatomy, AC depth, which is a shallow AC depth, less than 3 millimeters, uncontrolled ocular risk, glaucoma or other active inflammation or whatever, or unstable or unrealistic expectations. So as a rule of thumb, if spectacle does not meaningfully improve vision, then phakic IOLs will not solve the optical problem as well. So what is the ICL plan? The preoperative workup is the same as any other preoperative workup for phakic IOLs, in addition to making sure that the cornea is stable before planning for phakic IOL implantation. The timing of cross-linking is very important. You have to treat progression first before ametropia. You have to stop progression. So progression is detected, cross-link, then leave a stability window, what we call stability window, and then you can, if the patient is a candidate for phakic IOLs, you can consider phakic IOLs. The stability window, as I've just said, is not less than 6 to 12 months or more if you can. The refractive planning in keratoconus is a bit different because you take the manifest refraction of the patient, you look for the best corrective visual acuity, and you look also for the tomography stability before considering this, and to make sure that you're going to reach the phakic IOL target or the refractive target you are targeting. The evidence, there are many studies talking about the safety and the efficacy, and the safety and the efficacy of phakic IOLs in keratoconus patients is very favorable when selection is strict. There are also other combined strategies that you can do. You can do cross-linking first and then phakic IOLs, as I've just been saying. Then, or you can do ICRs if there is very irregular, a bit irregular. You can do cross-linking afterwards, as I've just said as well. ICRs first, cross-linking, and then toric ICL, toric phakic IOL. Trans-guided PRK cross-linking, whether sequential or the same setting, and then phakic IOL after the stability window. Or you can even do keratoplasty, and if there is a refractive surprise, or refractive, I mean error, ametropia, there would be, of course. You can consider then phakic IOLs. Post-operative follow-up for any phakic IOL, you look for the intraocular pressure, you look for the inflammation, all that stuff, day 1, week 1, month, 3 to 6 months, and then annually. So in summary, if you have a keratoconus patient asking for a refractive freedom, ask yourself a question: is it progressive or not? If it is progressive, stabilize the cornea. If it is not, then it's a stable cornea. If it is a stable cornea, is there a useful best corrected visual acuity? If no, then please do not do phakic IOLs in a patient who is amblyoptic. He's not gonna benefit. If yes, then look for the anatomy. If the anatomy is safe, then you can go and the expectations are realistic. You can go ahead and do phakic IOL implantation. So this is the take-home message. ICL is a refractive. Okay. It's a refractive rehabilitation tool, not an ectasia treatment. The best candidates are stable patients, stable, clear, anatomically safe, correctable, stabilize, regularize before doing intraocular correction, and the outcomes are very encouraging, evidence is there, and follow-up is a very important thing by monitoring both the implant and the keratoconus itself. Thank you so much.